All right. So Ms. Roberts, if I can start off with you, are you, is she, is
Yes.
she? Oh, you are still there. Okay. Um, can you speak to the impact of social determinants of health on outcomes for patients with genetically mediated or APOL1 type disease?
So there have been a number of studies I know that have been conducted at Mount Sinai where they have looked at the implications for social determinants of health, all types of social determinants, including access to health, environmental factors. We know that it clearly has an impact, and we need to do more research to see specifically if there is a difference in different determinants of various diseases.
Great, thank you. Dr. Nestor, this one I think I'll direct to you, and it's kind of, there are two questions that I'll kind of combine. So the first one is related to if one side of the family has kidney disease, how does that impact my risk of getting kidney disease, and how do I determine my individual risk? And the second is that if I've had kidney disease, in this case, the person specifically asked related to IgA nephropathy, how do I understand my risk of passing it on to my children?
I'll start with the IgA nephropathy one, and then hopefully you can, maybe I'll circle back to the other one. But the IgA nephropathy one, IgA nephropathy is a polygenic disorder, meaning there's genetic factors, there's environmental factors. It's what we consider these complex diseases like diabetes, lupus, all these other diseases we know of. And so it's very hard to determine risk. I will say, though, that a subpopulation of patients with IgA nephropathy have actually been found to have collagen 4A associated mutations, and that the phenotypes for both diseases can overlap. And so some individuals that we've diagnosed with these collagen-associated nephropathies actually had a clinical diagnosis of IgA nephropathy, but in fact had a molecular monogenic form of disease. And so it's not unheard of for a patient who has IgA nephropathy, especially if they have a family history. And these can be familial too. I know IgA nephropathy can, of course, be familial, even if we're not talking about the purely rare monogenic forms of kidney disease. It's not unreasonable to speak to the nephrologist about referring you or ordering you genetic testing. A lot of these commercial panels, I'm agnostic. I have no specific panel I like. Based on the situation, I'll order different panels. I like competing panels. I like competing commercial laboratories personally. And most of these kidney panels, quote unquote, gene panels include those genes of interest and other ones. And so it's not unheard of for individuals who have a diagnosis to undergo genetic testing almost as a screening to see, because we have diagnosed. I mean, it's going to be rare and it's unlikely, but it's not impossible. And so in terms of familial, there's kidney disease in your family. How do you determine your genetic risk? That's very, very hard to answer. Again, if we're talking about just chronic kidney disease and we're not talking about specific subtypes of rare hereditary forms where it's passed down, you've got multiple generations who have it, and you have an identifiable genetic cause, we're going to assume that the kidney disease is polygenic. Again, a mix of environmental and genetic factors. We have the genetic risk of APOL1, which was a tremendous, the large discovery of the 21st century in medicine. And, we don't necessarily have other factors that provide so much insight about the structure of disease, especially involving the kidneys. But, but I will say with APOL1, we don't necessarily know what the modifying factors are that cause disease. And so we understand that that's passed out long in this autosomal recessive way. And we know that if you have HIV or other disorders, you're more likely to have kidney disease. But we don't really know, if you're diabetic with the high risk variant and you control your glucose better, does that decrease your risk of developing kidney disease? Because more importantly, a significant proportion of individuals who have the high risk genotype go on to not develop kidney disease. So again, it just shows you we don't understand in this two-hit hypothesis, if you have the high risk genotype, what the other hits are. and we don't understand what the genetic and environmental modifiers are fully. We have an appreciation that maybe some infectious diseases like HIV certainly are a modifier, but we don't understand any of it. And so for anyone who has kidney disease in the family who wants to know their own risk, there's no answer to that. There's all these fancy things coming out of massive biobanks for polygenic risk scores to see, you know, if someone has complex form of kidney disease or common form of kidney disease, which we call complex diseases, polygenic disease. If you just have sort of standard chronic kidney disease, that's not monogenic, hereditary, rare, you know, they're trying to figure out sort of what environmental factors and genetic factors are modifying it in these big studies. And they've developed these scores, but no one actually knows how to make sense of those scores yet. And there's a lot of questions about how these scores are developed. The ones that make it to publication in big journals have a lot of validation studies to go along with it, but they're not really ready for clinical care. So my advice to anyone who's worried about their own risk, if they have it in their family, is really conservative. You know, you want to watch your weight. You want to make sure that you're seen by a person yearly, so you have your blood, your urine, and your blood pressure checked. And really, a massive modifier is weight. And so people who are heavy have a tremendous risk of developing kidney disease. And so managing the weight for the rest of your life, maintaining muscle, eating much more plant-based diet. I think those are the only things we can do to modify our risk, and just appreciate that if you have it in the family, that you probably have a bit of a higher risk, but the power of modifying lifestyle is still there. I wouldn't be, you know, that's still good advice.
So let me ask you this, as somebody who's been skeptical of the value of genetic testing in routine care, if I have a patient, or if a patient has, say, IgA-mediated disease, IgA nephropathy, if they had a genetic variant like APOL1, that might very well influence their risk of progressing to chronic kidney disease and or the need for kidney replacement therapy, so that there's significant value in getting genetic testing done to understand their risk and the risk for their offspring. Is that fair?
Yeah, except that I don't necessarily think that that patient is that those scenarios don't really tend to coexist in the same patient. You know what I mean? They tend to be ancestrally of different ancestry. You know, it's sort of a different distribution. It's possible because a lot of people in the United States are so admixed with so many different global populations of the world in their families, that it is of course possible that the risk you bring on one side of the world is also sort of the risk you bring from sub-Saharan African people who survived the Atlantic crossing during the slave trade and have descendants all along the Americas. That is of course possible, but they tend to not be the same.
I get what you're saying. But if somebody
yes,
had, then
absolutely.
let's change the underlying
disease. Okay, sure.
If somebody had diabetic kidney disease or what was labeled hypertensive kidney disease,
yeah,
testing for something like an APOL1 variant might help determine their risk of progressing to end-stage kidney disease.
So I have a very different viewpoint.
Okay.
Than I think Dr. Freeman. Dr. Freeman, of course, is an established physician scientist in this domain, whereas my science has always been in the implementation, how ready we are for prime time use of genetic testing and clinical testing. And so personally, I think APOL1 testing is really clinically ready in the setting of identifying individuals within a family who want to donate to their parent or family member who's got kidney disease. And they've got African ancestry, and there's a high suspicion that they have APOL1, and that the donor nephrectomy to that healthy person might be sufficient stress to then precipitate kidney disease if they were to donate, if they have the two high-risk variants for the APOL1 gene. So I think that's perfectly, and there's a lot of ethical issues about that, because if you then preclude someone from donating, and there's already such a discrepancy in living donor donation in Black communities in this country, it's another barrier. And of course, so I appreciate all the nuances and and also the community's desire to know status. So I appreciate all that and believe that's complicated and nuanced. I think APOL1 status, though, in terms of its relation to disease and disease progression, is still something that's in the research domain. We do get patients who are referred to us by nephrologists who want to know the APOL1 status, but really these are individuals who they've undergone kidney biopsy and there's nothing conclusive, and they've really done an extensive evaluation to try to assess the etiology of their patient's kidney disease. So they're not typically diabetics, but if they were diabetics, they would have had kidney biopsy evidence of diabetes. And so in these cases, these are people who had no evidence, really non-specific findings on kidney biopsy, who are then referred to us by a nuanced nephrologist who wants to know the status because they sort of understand how they're going to counsel the patient, and more importantly, because people can now qualify for clinical trials based on the status of that. And so I think that is another subset of individuals that I'm willing to say are now ready for clinical primetime testing of APOL1. But to inform your management or to try to give you insights on prognosis, that's a lot more complicated. We don't know what the modifying factors are. And so I'd say the kidney disease that's related to diabetes, if there's true evidence of that pathologically, it's going to be the diabetes. I don't know if they have the high risk variant, sure. You can hypothetically make that argument that that's going to help with progression, but who knows? We don't really know if diabetes truly modifies that risk or if it's like an independent risk.
Spoken like a true scientist.
No.
Dr. Oxberg, let me come to you now. We've had a couple of questions related to the kidney's ability to regenerate. And I recall studies that may have been published a long time ago and may in fact have been disproven now, but where kidneys were seen to enlarge after kidney donation, for example. Is that due to regeneration of functional tissue of nephrons, or is that due to expansion of the size of nephrons? And is it possible for the kidneys to regenerate after somebody has donated for transplantation?
Yes, these are two totally different processes, which are very fascinating. When the kidney in somebody who does a live donation, when that remaining kidney experiences the increased demand, and like I said, we have 15% of all of the output of blood from the heart rushing down to the kidney. It's a massive amount of pressure here. So the kidney knows when its other partner is gone, because it's now receiving all of this blood. So the kidney senses immediately when its functional demand is going to go up. And when that functional demand goes up, it responds by making more machinery inside the cells, which is a process called hypertrophy. And that means that these, if you do an MRI or look at the actual kidney size of an individual 4 or 6 weeks after they've donated, a healthy individual who's donated a kidney, that other kidneys may be increased in size 30-40%, which is a huge amount. And so it does, that hypertrophic growth does it increase the capacity of the kidney to process and do its job. That is an important part of our responsiveness to damage that I really didn't talk about, because it's a different beast and regulated by totally different genes and physiological stimuli.
Great, thank you. That's very helpful. Ms. Roberts, can I come back to you? So there's obviously been some controversy about when genetic testing should be done and how it's useful. If you were to talk with other patients, what would you want them to know? And at least as importantly, what would you want the physicians or the providers caring for them to know?
That's a complex question because I think families often influence whether or not people are willing to undergo genetic testing. And people continue to have concerns about genetic testing because they don't really appreciate what the implications are for their families overall. And frequently, and I've had this experience, you'll be given a genetic test for to look for one condition, but you'll get a report back that tells you about all kind of other things that you are apprehensive about. For instance, I have HCM, hypertrophic cardiomyopathy, which they believed was genetically driven. We did a genetic test. We did not find any genes that would justify the fact that I have HCM, but they said you do have a muscular dystrophy gene. Clearly, I don't have that condition, but now we've created a situation where when I'm asked if I am aware that I have any conditions, I need to expose this. So I think people have to weigh the benefits of getting the information and if in fact there are therapies and treatments that can be applied versus having the information and putting yourself and your family at risk in terms of potential insurance coverage and other factors.
And that really sounds a lot like what Dr. Nestor was saying in terms of, doing genetic testing just to understand the genetics, as opposed to being able to really apply it to somebody to help reduce their risk of developing kidney disease or progressive kidney disease.
Exactly.
Great. So Dr. Nestor, if I can come back to you. So somebody has asked the question, how can I get tested for genetic kidney disease? So if somebody wanted to get tested, how could they make an appointment, whether with your group or with another group, to get that testing done? Sorry, you're muted.
I was just
I had to
answering
say that
someone's
to somebody at some point.
I was just answering someone's question about the same thing. Basically, now you've got all these commercial laboratories that offer genetic testing that have streamlined the testing ordering system, and it's often covered as of today. It's often still covered by insurance if there's a good argument in the note in the documentation for it being medically necessary, and so it's often covered. And so these commercial laboratories have made it quite easy for nephrologists across the country to order genetic testing. And some of them offer some additional resources for the provider who's going to order the testing, and also for the patient to go through some financial clearance before they run the test to make sure it's covered. And so anyone can now get tested by their nephrologist if their nephrologist wants to order genetic testing. And the question I was answering for someone else was, the question was, we do genetic testing, but do nephrologists across the country do genetic testing? And I mean, I can only answer that anecdotally, which is that I get a lot of emails from nephrologists across the country who have already done the testing and now would like to make sense of the results for their patient. And so they'll email me reports, and certainly more so now than before the pandemic, certainly more so now than 2 years ago. So I think, and they're not just all from this one commercial laboratory we all know of. There are all these other commercial laboratories that are in that space now, offering efficiently easy to order testing for nephrologists to do as part of their workflow.
And that's actually always been one of my mantras, and you probably heard me say it. Don't do any testing if you don't know what to do with the results. And so it really speaks to why you go to somebody who has expertise in the testing rather than just go to somebody who can do it.
Yeah, the thing is, it's true. Sometimes if you have a suspicion that someone has an ADPKD or a cystic, that the reports are good enough to, if you find something that's truly, that it'll be labeled as pathogenic or likely pathogenic. I'm not talking about variants of uncertain significance because that is not a diagnostic finding. But if you find something, usually in the description, there's enough there to see if the phenotype matches what you have, and then enough for you to be able to then look it up. But these are very rare diseases. And so, no one's an expert in all these rare diseases. So I have actually a friend of mine, we trained together in fellowship. When she came back to Columbia after being in private practice, I sent all my patients to her because I was a researcher and I didn't have continuity clinic, but she did. And so now I'd say that she's the leading expert in how to manage these rare monogenic diseases, because where, a nephrologist might have one nail patellar syndrome, she has five, and so I think that's how we learn. We learn from collaborating and seeing patients, following patients for a long time, and really becoming friends with people who are then going to follow your patients and give you feedback about how the course is going based after the genetic diagnosis is made.
Yeah, that was a piece of advice that I got when I was finishing fellowship. Look for your niche within what in the world and develop it. And your colleague obviously did. Maybe not on purpose, but that's sometimes the best way to do things. Dr. Oxberg, can you speak to the potential for kidney organoids to develop gene therapies? I know you've done a fair amount of work with building kidney organoids, but would it be possible for an organoid to be able to deliver some of the therapies, for example, that Dr. Friedman talked about?
Yeah, that is the hope. I mean, as Dr. Friedman pointed out, there are many diseases, particularly genetic diseases, that we really cannot investigate in the mouse very productively, especially if we intend to develop, for example, gene targeting therapies that reverse mutations. So one particularly interesting area is, I think, Glenda, discussed it briefly, is polycystic kidney disease. Because in polycystic kidney disease, we know that we can generate, Bino Friedman's group has been generating organoids that have developed cysts that have similarities to the types of cysts that develop in human beings. The organoid can be based on cells from an actual patient who we intend to treat. And the organoid provides a testing platform with which we could maybe assess different approaches to do that very subtle gene manipulation and change the conformation of the gene to a non-disease state. So yes, I think that there's huge potential there. The tools are ready, and there's a lot of technologies that are coming together in the next couple of years, and it's almost like running into a candy store for a kid being a scientist now, because there's just too much, like too much to grab. And so that's the situation we're in, and I do believe that these models are going to usher in a new generation of therapies, and the advance we've seen in sickle cell recently has been really given a lot of people a lot of hope that kidney disease could be on the horizon, right?
Dr. Friedman talked about, how much the science has advanced in the last number of years, and particularly as he showed in the last several years. And, probably if it hadn't been for the pandemic, things would have advanced even faster.
Yeah. Yes, and I think we will have having as strong a voice in Washington as possible advocating for kidney disease research, I think, is very important, and we've been benefited from interest at the federal level before, and I hope that will continue.
Absolutely. This administration certainly was a big supporter of kidney disease in the first Trump administration. And you're right that, the more that we advocate for the research, the more likely we are to get it. And I know that ASN has had a very strong voice in advocating for kidney research. Ms. Roberts, if I could turn back to you. One thing that I often hear discussed when people talk about research is, what should the endpoints be? And Dr. Friedman, in talking about the Apollo studies, talked about um, the reduction in proteinuria. How do you look at whether that's a sufficient endpoint, or should we be looking at endpoints related to kidney function?
Well, I have a slightly different perspective than a lot of clinicians do. And that is when clinicians look at endpoints, you're interested primarily in the numbers. You're interested in what impact it has on creatinine or what impact it has on UACR. From a patient perspective, I'm interested in what impact it has on the quality of life. You know, many patients, like I do care about my EGFR. I do care about my creatinine, but I also care about my ability to live my life. So when we think about endpoints, I encourage people to focus on the patient's priorities, preferences, and desired outcomes, as well as the laboratory values. I want to live.
Thank you again for reminding us about what's really important. As I've said to you many times, you always do bring us back to what's really the focus of things. And certainly the focus that you just talked about should not only be the case in a research project, but any time a physician is taking care of patients. It should not be, that we provide a treatment simply because we can provide a treatment, but we provide that treatment which will afford the patient the best opportunity to live the life that he or she wants to live.
Yes, exactly.
I will add to that in the same vein, the fact that there are some individuals who are referred to us, and after a very extensive conversation myself and the genetic counselor have, we don't actually recommend genetic testing for them because, it's very burdensome, especially there's certain patients who are not reassured by, and they have undergone extensive testing, and this is just one more test that's going to be negative, or is going to actually give the middle results, which are these variants of uncertain significance, and they're not actually going to reconcile with it, and it's actually going to cause them a tremendous amount of distress not knowing, because we don't have any knowledge of what these variants mean for another few years and maybe another decade for some of them, and all these other gene causes and genetic variants to be identified as culprits. And so it really takes tremendous amount of pretest counseling and getting to know the patient and what's important to them, because sometimes it's just too burdensome to put this type of testing on them. This is not a BMP to get a creatinine value. This has implications potentially for them and their family, their community. And so I think that's an essential part of genetic testing, is to see what's important, and if your patient's actually going to be able to appreciate the uncertainty that the overwhelming majority of the results will bring.
And again, I think that really brings up the importance of not having the testing done in any random office just because it can be done, but of having the types of people that you spoke about, genetic counselors, as well as physicians and scientists who really can dig into the details of the meaning of those tests.
And if I could add, Dr. Nestor, I think it is equally important to have the conversation with the patient to make that decision. All too often, we still see the case where clinicians decide that it will be too scary for me to get the data, when in fact, they should have a conversation with me and other patients to make sure that we understand the potential risk, the potential uncertainty. And quite often, the patient will say, I don't want to know. But in other cases, a clinician might think, oh, the patient really wouldn't want to know this because I've seen them and their family, when in fact, I do want to know because it might cause me to change my lifestyle or make other decisions that you wouldn't expect me to make, even when the data isn't definitive.
Yeah, I agree completely. And the thing is when it comes to APOL1 testing, that's where we have a tremendous amount of body of literature of community-based projects that have been done where community perspectives have been offered on this. And this is why I'm skeptical to just test everyone, because of those papers, those focus groups, those communities initiated data that have spoken about the importance of them knowing whether and living with uncertainty. And so I think actually it's the patients who are being referred to us by the nephrologist, who those decisions are made without a discussion, shared decision making with the patient. I think that's the thing, because my decision not to recommend testing for someone is never done in a vacuum. It's only ever done with shared decision making of a patient, because it's true. Just like some patients may not be able to deal with the uncertainty, other patients are quite comfortable with the uncertainty as long as they have some additional information.
I'm just going to ask again, if anybody has questions, please put them in the chat. But I wanted to say this conversation is really a lot like the conversation that we really want to have with patients who are approaching the need for kidney replacement therapy. We want to be able to talk with them about the different treatment options and find the option that best suits their lifestyle, whether that's transplantation, home dialysis, or in-center dialysis. Ms. Roberts, I don't know if you have thoughts on that. I should say it better. I know you do have thoughts on it. I wish you'd share them with me.
Oh, well, I think you did a great job of, in framing the question, addressing sort of my attitude about the question. I can't emphasize enough the importance of engaging with the patient and communicating at a level that the patient understands. And if you're dealing with a patient and they don't seem to be engaged, they're not giving you feedback, it might be that they don't understand what you're saying and they're not comfortable raising issues. So my recommendation to all clinicians is, if you have a patient who comes in and they're nodding their head and they're taking notes and they leave and they don't ask questions, the burden is on you to make sure that I understand, that you're presenting it to me in a way that is simple enough for me to understand, and that you are creating a climate that encourages me to ask you additional questions so that I am better prepared to use the information that you give me to make changes in my own life.
I think that's a really great point. And one of the things that I have found incredibly valuable is taking patients who have volunteered to sort of serve as references for patients who are going through the process. Because as I've been told, I've never sat in a dialysis chair. I've never had a kidney transplant. So as much as I know about it, I don't know what it's like to go through it. Whereas somebody who has gone through it understands it in a completely different way and can speak to a patient approaching that point about the impacts on quality of life in a very different way than I can.
I completely agree. You know, the lived experience is information that I think has been missing from a lot of the research that we have done. And I am pleased to see more and more clinicians and researchers involve patients in their research so that you can get the perspective of what it's like to go through dialysis. And for those of you who know me, you've heard me say dialysis is hell. I want to be real clear. Dialysis is hell. So if you can recognize that it is going to be difficult and that dialysis is not for everyone, and be more open and receptive to saying, well, maybe what we want to do is palliative care here and make you as comfortable as you can and enjoy the quality of life that you can for as long as you can.
Great, thank you. We're just about out of questions, so let me come back to each of our speakers and just ask you for your closing thoughts. So, Dr. Oxberg, if I can start with you.
Well, in closing, I think this has been tremendously informative. It's very exciting to learn about all of the steps forward we're taking, or that have been taken in clinically understanding the value of genetics. And it's really an era in which I think the technology and the medicine are going to come together to give us new tools to actually not just use those genetic findings as advice possibilities to give advice, but actually to base new cures on them. And that's what we're seeing already. And it really is a hopeful time. And I look forward to an explosion of new treatment strategies, particularly in nephrology, because I think kidney patients have been in a bit of a desert therapeutically.
Great. Thanks so much. And Dr. Nestor, if I can come to you.
When I was in medical school, the APOL1 risk variant came out in 2010, and it's why I not only wanted to become a nephrologist, but I wanted to become a kidney geneticist. And so in the last 10 years, we've had this opportunity where technology and access has been met with clinical preparedness. But I'd say there's still a lot more to do. A lot of this is still being done, and hopefully research funding will continue to support these types of endeavors. So the next 10 years, it will be another explosion where it's actually going to come closer to affecting the day-to-day lives of patients who are suffering with kidney disease.
So thank you for that. But before you go, there was one question that just came in, which is, have you seen any progress using genetics to make immunosuppressants less nephrotoxic? So in other words, understanding the way that different patients metabolize immunosuppressants.
So that's in the domain of pharmacogenomics and that's really immunosuppressants. I think there is one immunosuppressant agent. I just saw a talk about this at NKF. Adriana Hung at Vanderbilt does a lot of this type of work, and she believes, this type of testing, pharmacogenomic testing, should be done a lot more clinically, bedside specific. A lot of the medications that they're able to test for are common ones, aspirin, ticagrelor, etc. And I believe there was one or two agents related to immunosuppressants that have some data to support insights that can be offered based on patients' genetic makeup. But the problem is that a lot of people don't know how to make sense of the results. And with pharmacogenomics, there's not as easy of a pipeline to ordering those testing as there is commercially for a gene panel, for example, of a large amount of genes that are associated with kidney-associated diseases. But I think when it comes to pharmacogenomics, we still have a lot of barriers in terms of implementing more widely clinically as part of physician workflows, and then how to make sense of it, and also what medications are included. But there is a growing body of evidence to support insights given on I think it's tacrolimus related to pharmacogenomic results.
Great, thanks so much. And as should always be the case, Ms. Roberts, I'm going to give you the final word and let you provide us the patient perspective on all of this.
Well, thank you for that. One of the things that I would like to emphasize is the importance of communicating to patients that it takes time for these therapies to actually get to market. I think that a lot of patients have become disgruntled because they hear about exciting new possibilities and then it feels like nothing happens. And I think we need to set realistic expectations. Be excited and hopeful that there are therapies and treatments, but communicate, what the clinical trial process is like and how long it actually takes. I encourage you to encourage patients to participate in clinical trials so that we get more data faster. And I encourage you to share with your colleagues about the importance of educating clinicians in advance of the delivery of the drug, to bring them up to date faster about what's coming down the pipeline, to increase their confidence so we don't have to wait 17 years to develop a drug and then another 17 years before clinicians are comfortable with the drug.
Great, thank you so much. So we'll conclude, but I'd like to conclude by thanking Rogosin's IT team for their support in actually putting the webinar on. I'd like to thank our development team, Ms. Christina Bishop-Feeney and Ms. Michelle Stefandel, for all of their work in helping us to get the speakers together, get the continuing education credits, and actually get all of this in front of all of you today. And finally, I'd like to thank our speakers, Dr. Leif Oxberg, Dr. Barry Friedman, Dr. Jordan Nestor, and Ms. Glenda Roberts. This webinar has been recorded and will be made available. We'll let you all know when the recording is available. Thank you again for joining us, and thank you again to our speakers. Have a good afternoon, everybody.